Our topic of discussion today will be pain. As you hear the name, I guess everybody must be thinking, what is to study about pain? It is so hated that we don't even want to talk about it. And so mostly people try not to mention about it also. But pain is actually a very significant part of our health. Pain has been one of the most mysterious and elusive aspects of illness and treatment. It is fundamentally a psychological experience, and the degree to which it is felt and how incapacitating it depends in large part on how it is interpreted. That is how I feel the pain. That only denotes how heartful the pain is to me. Normally, people think of pain as an unusual occurrence. We actually live with minor pains all the time. We have some kinds of pain. Generally, we feel pain most of the time in our life. These pains are critical for survival because they provide low level feedback about the functioning of our bodily systems. Feedback that we use often unconsciously as a basis for making minor adjustments. Like if I'm feeling a kind of discomfort or pain when I'm sitting on a chair, then I might change my posture to adjust. Or if I'm feeling some kind of discomfort while sleeping in a position, or I'm feeling a kind of slight pain like sensations or triggered like that, I can roll over, or I'll obviously readjust so that I can be relieved of that discomfort. Pain also has important medical consequences, as it is the symptom that is most likely to lead an individual to seek a treatment. Like if we are hurt, then the pain might be a valuable cue that the tissue damage has occurred. Okay, if because of the pain we can understand how severe it is. So what can be it indicative of? It's a breakage of a limb or a tissue damage or a ligament tear, like that. Now, pain is also medically significant because it can be a source of misunderstanding between a patient and the medical practitioner. Now, why? Because from the patient's standpoint, the pain is the problem. We generally go to the doctor with the complaint of the pain, but for the doctor, the pain might be a byproduct of a disorder. That is, what I am actually manifesting a pain, just a simple pain, it might be a manifestation of a disorder or a disease that is there in me. So for the doctor, it is generally the effect of that disorder that is causing the pain. But for the patient, most of the time they come with the problem of the pain. They report pain as the main cause of their discomfort. Now, pain has psychological significance also, because both depression and anxiety worsen the experience of pain, and this has been found by a study by Vowels et al. In 2004. Now we are coming to the types of pain. There are actually two main kinds of clinical pain. One is acute and the other is chronic. The acute pain typically results from a specific injury that produces tissue damage, such as a wound or, as I said, a broken limb. And then acute pain is usually of short duration, that is about of 6 months or less, while when the pain is experienced, when it is going on, it can also produce substantial anxiety, and so the patient may search for the avenues for the relief from the pain. And in case of the chronic pain, it is basically, say, chronic pain also start with an acute episode, obviously, but it generally does not go off with treatment. It stays. It does not decrease with treatment or the passage of time. However, there are several kinds of chronic pain. So there is a thing. So obviously, when I was talking about acute pain, as it persisted for 6 months or less, then when we are referring to the chronic pain, obviously the chronic pain will be persisting 6 months or longer. That means it's more than the 6 months, because till 6 months or less it was acute pain. So in case of the chronic benign pain, that it persists for about 6 months or longer, it is relatively unresponsive to the treatment. And this kind of pain generally involved any number of muscle groups. For an example, we can have a low back pain. Many of our parents or some of our relatives or many of our acquaintances report of having a low back pain all the year round. But they stay with the pain and they do not really are so eager to get the treatment. They are actually uncomfortable with the pain, but they live with it. Then another kind of chronic pain is the recurrent acute pain that involves a series of intermittent episodes of pain. Now, why it's recurrent acute? Because it's acute in nature, like it obviously will be less persistent than the chronic one, but as it's recurrent, it will come again and again. For example, like a migraine headache episodes. When it is coming, it is for the acute period. It's coming for there. It is staying for some time, 2 to 3 days, the discomfort stays. But after that, it goes off. But it comes on again. So as it comes again and again, it's recurrent acute pain. Then there is chronic progressive pain. This chronic progressive pain, it persists longer than 6 months and increases in severity over time. Typically, it is associated with the malignancies or the degenerative disorders, like we can say of the arthritis. The arthritis, as the time goes, it actually worsens. The pain increases. Now, we should actually try to differentiate between the acute and the chronic pain. The distinction between chronic and acute pain is important for the clinical management, because as the nature differs, their management and treatment will obviously be different. Firstly, the acute and chronic pain, they present different psychological profiles also, because chronic pain often carries an overlay of psychological distress and a form of psychological anxiety or discomfort that complicates the diagnosis and its treatment. Why this happens? Because they actually realize that the pain actually does interfere with their daily activities, the desired level of activity or performance that they want to achieve, that gets actually interfered or complicated by this pain. And they also realize that this is beyond their control. They cannot actually control this pain that they are experiencing, and this fact actually produce a psychological distress in the pain patients. So depression, anxiety and anger are common emotional experiences that actually exacerbate the pain and the pain related behaviors. Thus, pain and depression, they are heavily entwined. Now, some chronic pain patients develop maladaptive coping strategies, such as catastrophizing their illness, engaging in wishful thinking, or withdrawing socially, which obviously further complicate the treatment. Now, the second reason to distinguish between acute and chronic pain is that most of the pain control techniques, they control acute pain but at less successful in controlling the chronic pain. Why? Because it requires individualized techniques for management. Different people experience chronic pain in different way, and so how to deal with it, how to manage that actually needs a specialized, individualized attention. But that is not in case of the acute pain. Now, chronic pain also involves a complex interaction of physiological, psychological, social, and behavioral components, much more than in case of the acute pain. The psychological and the social components of pain are important in part because they are an integral aspect of the existence of pain and influence the likelihood of successful pain programs. Now, let's see the physiology of the experience of pain. The experience of pain is basically a protective mechanism to bring into consciousness the awareness of the tissue damage. As I said, whenever you're hurt, as you're having the pain, you can realize that there is something really wrong in this hurt. So, what pain is doing is it's actually protecting you, and it is bringing into your conscious awareness, into your focus of attention, the problem that might be there in your body. Unlike other bodily sensations, the experience of pain is accompanied by motivational and behavioral responses such as withdrawal and intense emotional reactions such as crying or fear. Now, this we know because generally whenever we get hurt, either we cry or we become very afraid of the situation, or we try to withdraw from the situation. Scientists have also distinguished the three kinds of pain perceptions. The first is the mechanical nociception, that is pain perception which results from the mechanical damage to the tissue of the body. The second is the thermal damage or the experience of pain due to temperature exposure. And the third is referred to as the polymodal nociception, a general category referring to pain that triggers chemical reactions from tissue damage. Now, these nociceptors in the peripheral nerves chiefly are delta fiber and A delta fiber and C fiber. These nerves first sense injury, and in response to this, they release chemical messengers. These chemical messengers are conducted to the spinal cord, where they are passed directly to the reticular formation and thalamus and into the cerebral cortex. These regions of the brain in turn identify the site of the injury and send messages back down the spinal column, which lead to the muscle contractions, which can help block the pain or the change in other bodily functions such as breathing. So how they help? This kind of messages that actually help in relieving the pain or the tension a bit. The motivational and the affective elements of pain appears to be influenced more strongly by the C fibers, which project onto the different thalamic, hypothalamic and cortical areas. Processes in the cerebral cortex are involved in cognitive judgments about pain, including the evaluation and evaluation of the pain, about what actually it means. Evaluation means how the pain matters to you. What is the meaning of pain to the person who is experiencing the pain? The psychological and the neural mechanisms of affective dimension. This is affective dimension. So the psychological and the neural mechanisms of the affective dimension of pain are critical aspect of pain experience. The affective dimension of pain is made up of feelings of unpleasantness and negative emotions associated with the future concerns. Now, researchers have called this concerns of secondary affect. This was actually named by Price in the year 2000. Pain sensations, intensity, and the duration, all this interact to influence the pain. Its perceived unpleasantness and related emotions through the central network of pathways in the limbic structures and thalamus, which direct their inputs to the cortex. That means all this together, the sensation of the pain itself, how intense the pain is, and for how long you are experiencing the pain, this total thing actually interact and produce the affective sensation related to the pain. That is how I will experience, how I'll define, how I'll evaluate my pain as. In the cortical regions of the brain, nociceptive input is integrated with contextual information about the painful experience, which contributes to the strong emotions often experienced during pain and which can themselves exacerbate the pain. The overall experience of pain then is actually a complex interaction of these elements of the pain experience. So this was actually shown by Meagher, Arno and Rudy in 2001. Now this is how the physiology of pain experience work. Now we are coming to the neurochemical base of pain, and it all started in the year 1972 when Acute et al. Uncovered the existence of endogenous opioid peptides. Now, what are these endogenous opioid peptides? Opioids are opiate-like substance. They are produced within the body that constitute a neurochemically based internal pain regulation system. So, these are actually our body's regulation mechanisms. And these are produced in many parts of the brain and glands of the body, and they project into specific and selective receptor sites in various parts of the body. So opioids are the control mechanisms of pain that is produced in our body. It's our self mechanism. These endogenous opioid peptides are generally of three types. One is the beta endorphins, which produce peptides that project into the limbic system and brain stem, among other places. Then there is proenkephalin, which are peptides that have widespread neuronal, endocrine and central nervous system distributions. And the third is prodynorphins, that is found in the guts, the posterior pituitary and the brain. Each of these types of peptide of the opioid peptides have several forms with different potencies of pharmacological profiles and receptor selectivities. Now all this is from the work of Akil in the year 1984. Now these endogenous opioid peptides are then what are they? They are actually important natural pain suppression system of our body. They work as pain relievers, or what we can say in common term, these are the natural painkillers of our body that is produced by our body itself. Now we are left with the factors of developing chronic pain and the different pain management techniques. Now we will be discussing this part of the topic in our next session. So till this is the first part of the lesson of pain, and the rest of the part will be covered in our next video. So if you have any doubts regarding what have been taught till this, you can obviously post your queries over here or directly reach out to me in the doubt clearing classes. Thank you, class.